Hey y'all, welcome back to my channel. I'm Muriel, this nurse Muriel. Hey to my new subscribers, thank y'all for hitting that subscribe button. To my oldies but goodies, how y'all doing? Thank you for tuning back in. So today y'all, I am off today. I worked last night. I did a 12-hour at my PRN. It was good. It's always something, you know. They had an agency nurse there, and that was her first time in the facility. And the hall they had her working on, y'all, has 8 tube feeders. Now, I don't know why they make these decisions when they move people around in the building. But it was broken up pretty okay at one point. There were like 4 tube feeders on one hall and 5 on another. They put like four of the tube feeders on the other hall. So that one hall has about 8 tube feeders. Y'all know the med pass for tube feeders is kind of lengthy, and the time that they are scheduled when you're working night shift is usually like midnight and 6 a.m. Well, you know, 6 a.m. is when they give the bulk of meds for all the patients that are scheduled at 6 a.m. So what I do, y'all, and this is a little tidbit for you guys. If y'all want to do this, you can listen to me, not listen to me. I suggest you change the timing of the meds just in case DHEC comes. What I do is I start my morning med pass with just my tube feeders around 3 a.m. I'm not about to be giving tube feeders their medication pass at 5 a.m. along with my PO meds, because that makes the morning med pass lengthy. So I go ahead and I give my tube feeders their meds at 3. I start at 3 a.m. I'm usually done with all the tube feeders, just the tube feeders, around 4 a.m. And then I sit down and I take me a little break, a little breather or whatever. Because, you know, after doing those tube feeders, and y'all know that they get the bulk of their meds at 6 a.m. and 12 p.m. in a lot of facilities. After doing all of them, I need to take a little break. So I sit down for about 30 minutes or whatever. And there is something that I needed to chart that I forgot to chart. I go ahead and, you know, try to think of whatever I need to chart at that time while I'm sitting down taking the break after I do my tube feeders. And then, y'all, I complete the rest of my med pass. Because, just like I said, tube feeders alone, if you have 4 to 5 tube feeders, they take about an hour. So imagine that hour plus the additional hour and a half, 2 hours to pass meds to your other patients. Now, you know that you can go into computer and you can change the times of your med administration. A lot of people don't think about that. But if the meds are scheduled like 3 times a day, what's the difference in getting them at 12 noon, 6 p.m., and like 3 a.m.? There's no difference between getting them at 12 noon, 6 p.m., and 6 a.m. and getting them at 12 noon, 6 p.m., and 3 a.m. We do know tube feeders are normally scheduled meds at 12, 6, 12, and 6. So I just changed it to 3, sometimes 4 a.m. because even if I schedule them for 4 a.m., I can give them at 3 a.m. I can start at 3 a.m. That way, if DHEC happens to come in and see you, you know, want to watch your med pass or whatever, you're justified in why your tube feeders are already done because they were scheduled at 4 a.m. That's just the way I like to do it, y'all, because I like to get my tube feeders out of the way and then do, you know, the PO meds, the blood sugars and stuff like that. Some people just go through and do all their blood sugars, then they go back and do their tube feeders, and then they do their PO meds. Some people do all at once. I will never be the nurse to do all at once because I'm not, after fighting to stay awake all night, I'm not about to get up and do a 2.5, 3 hour med pass in one swoop. I'm not going to do that. So anyway, the nurse, I got kind of off track. The nurse, she was on the hall that had like 8 tube feeders. And I just felt like that wasn't fair, that wasn't right. So I actually went and did 4 other tube feeders myself that did their medication administration. Had to insert a G-tube because the G-tube was out. Change their bags if they needed to be changed. I actually did that for 4 of the patients, so she didn't have to worry about that. Yeah, so that was something I did last night. I don't know why like I said, I don't know why they put all those tube feeders on that one hall. And now the hall that used to have like 5, they only have 1. So other than that, it was a good night, y'all. I had a good shift. I did have to notify the doctor of something that a patient said, a resident. Lord, y'all excuse me, because now this new job, I'm back to saying patient at the new job, but I still dabble in long-term care, and you say resident in that setting. But so the resident stated that she's been complaining about this for days. And so I took a look at where her complaint was, and there is something there. And so I had to call the MD because she wanted something for pain. She wanted something for pain, y'all. I saw she didn't have an allergy to Tylenol. She complained about it like 3 in the morning. Y'all don't follow me. Don't follow me up. I looked, she doesn't have an allergy to Tylenol. She didn't have anything that ordered that would interact with Tylenol. I went ahead and gave her the Tylenol because I'm not going to sit there and let her be. I'm not going to call the doctor at 3 o'clock in the morning about a complaint of pain when Tylenol should be on the standing, should be a standing order anyway, especially for a patient who doesn't have, an allergy to it. Like, why wouldn't you give a standing, why wouldn't you have a standing order for Tylenol? It makes no sense to me. Anyway, I went ahead and gave her the Tylenol. And then I called the on-call around 6 o'clock because I'm not going to call an on-call before 6 o'clock for something that's non-emergent. And then I called the on-call at 6 a.m. And then I told them the complaint. I told them what I observed. And I told them the patient had a complaint of pain, but they don't have anything PRN. Is it okay to go ahead and put a PRN order for Tylenol? And of course they said yes, So I went ahead and put that order in before I left. But the fact that this patient had the patient stated that she complained of pain in that area, she said it's been for days. And when I look at the area, there's a big raised area, like it's about that. I can't explain. It's a big raised area there. And so I put it in, and I couldn't quite figure out what it was because I couldn't tell if it was, a hematoma. I couldn't tell if it was muscle, from muscle rigidity. I couldn't tell if it was from a broken bone, but the pain wasn't as severe as to where I would think it would be a broken bone. So I did notify, and I put it in MD's book. But when the morning staff came in and it was a regular tech that was working, that works with that patient, that tech said that this patient had been complaining about it for a couple weeks. Y'all. Had been complaining of pain in that area for a couple weeks. And she did notify the nurses. And in my mind, I'm thinking, okay, these nurses probably just gave the patient some Tylenol, didn't document it, didn't anything, just gave them some Tylenol, took care of the pain, and just rolled on about their business. Don't know if they actually looked at the patient's, that part of their body to see if anything, don't know. So, and of course, nothing was documented because when the patient complained of the pain and I went and looked at the area and I saw that it was a raised area there, of course I'm going to the notes to see if anything's been documented about it. I did that at 3 a.m. when she complained of the pain. No documentation about it. Of course, I went through the doctor's book, the MD recommendation book, to see if anybody had even placed that in the MD recommendation book as a complaint. Of course, no one had it placed in there. So, y'all, I put it in there. Hopefully, it'll get handled. Today is Saturday. Hopefully, Monday when the MDs come, the MP come in, they'll take a look at it and they'll figure out what it is. It could be something minor, but you never know, But it's just the fact that, the patient told me it's been there for days. The tech told me she's been complaining about it a couple weeks. Now, mind you, the tech said, when I told the tech that there was a raised area there, the tech said that she didn't see a raised area there when the resident complained about it, had been complaining about it. But I told her, if I could say this without saying too much, hopefully this doesn't violate any HIPAA regulation. So the patient would complain of pain to her shoulder. She said shoulder pain. So I'm assuming they just went and looked here and didn't see anything and went on about their business. But actually, if you look back here at the back, like I say, the back of her scapula, there's a big raised area. So I'm just going to assume that they didn't look thoroughly at, although I would think that they would catch that when they're bathing her. I don't know, y'all. I don't know what the deal is, but it's something there and it had never been addressed. So I think it's gotten to the point now where when they see me come to work, because I had that moment where I was like, I'm not coming back here because the nurses are so incompetent. I think it got around to the building and now everybody is like trying to, I don't know if they're trying to be like on their P's and Q's or whatever, because I notice now when they give me a report, they try to be, some of them, they try to be a little thorough. I've noticed when I'll come into work sometime, and I let them know, instead of me just fixing things now, I message the nurses individually, and I let them know what I find when I work behind them. So there was a nurse, second time I found this. The first time I didn't really pay much attention because the medication was just, based over the counter meds. It wasn't some center, whatever. Last night I came into work. I went in this patient's room to administer medication. This patient's gabapentin and tramadol was sitting there on the table from the last administration. Mind you, the last administration was probably around 2 p.m. This medication is just still sitting there on the table, and the patient is kind of like out of it or whatever. And so I had to throw that away because that was basically a missed dose. Of course, it was already signed off because the nurse who worked before me didn't stay around to make sure that the patient took the medication. So, of course, that's a missed dose. The patient didn't get that. But then I'm looking at the patient's her level of alertness, and she just as drowsy as she can be. So I don't know what's going on with the patient. They need to reevaluate maybe DC and some of these scheduled narcotics that she's on, even though y'all know how I feel about, if y'all don't know how I feel, tramadol being a narcotic, So yeah, I did, because this is the second time I found this when I came in behind the same nurse. So I did text this nurse, and I did let this nurse know, hey, this patient is blah, blah, blah. They're not, because normally that patient used to just take their meds or whatever. But this patient has their level of, what is the word? It's not a level of alertness. It's the level of, what is the word, y'all? I'm getting older and I'm forgetting words. If y'all know what I'm talking about. I don't think it's alertness, and it's not cognition. It is alertness, but it's another word for it. But that level of them being awake and alert has decreased over the last 3 weeks. I noticed last week this resident was real lethargic. But anyway, so I threw that dose that was sitting on the table away, and I woke the resident up, and I was like, hey, are you able to take these medications? Are you having any pain? What's going on? You haven't been blah, blah, blah. And the patient told me, yeah, they wanted to take it or whatever. So I actually placed the because the patient's mouth is all dry. So I gave the patient some water to drink first. Note to y'all doing 6 a.m. med pass. Always give the patient a sip of water before you give them. Now, this wasn't a 6 a.m. This was a nighttime med pass, but the patient also got it at 6 a.m. But always, and when you're doing your 6 a.m. med pass and you have to give a patient a pill, give the patient a sip of water before you give them a pill. Because just imagine putting a little tiny pill in a dry mouth. How it can get stuck in their throat. Just give them a little bit of water before they take their medication. Give them a sip of water before they take their medication. But I made sure I gave her a sip of water, or more than a sip. She drank actually a good bit. And then she took her medications. But yeah, that's something something else that happened last night. Found those medications just sitting on the resident's table from the last med pass. And I spoke with the oncoming nurse when I left this morning. She works about 3 days a week with that patient, and she said she noticed it too, and she's going to make some recommendations to the NP to DC, or make some of the medication PRN instead of scheduled, because the patient is not up and doing things like they used to do that would cause a lot of pain, and then they just seem like they're real lethargic all the time. So that's good advocating for your patient, and that's stuff I like when you notice a change in your patient, think of what changes may need to be made to their medication and stuff like that. Because why is this patient taking this and they're always drowsy? They're always it could be too much. It could be, the medication could be making them like that, or they may be going through some type of depression, or something. Just let the NP, leave it in the ND notification log or whatever, so they can address it. You make a note about it and put in there that ND notification is made, so that you can cover yourself. Because I'm sure when that patient family comes, they see that decline themselves. You're there 3 days a week, 4 days a week. You see the decline. Notify the doctor about this decline. This patient may need to be put on some type of antidepressant or maybe they're getting too much of this medication in their system, and maybe they're not filtering it out, and it's building up a level of toxicity in their body, or something's going on to where this patient is now went from the patient that gets up every day, rolls himself around, interacts with you, can take their meds, take their cup of meds from you and take it themselves, to now they like this in the bed, and barely want to open their eyes. Like, something has occurred, something's going on. So notify the MD. This video was supposed to be about my new job. I was supposed to be telling y'all the ins and outs of my new job, but I don't want the video to be so long, and it's already like 17 minutes.
Miles.
Let me just tell y'all about my new job. I'm sorry, this video is probably gonna be like 30 minutes. So just to give y'all some insight on the new job. So for those of you who are new, I now work in the mental health. I have a government job. I got a government job, y'all. Working in mental health. Something that I said I would never do, y'all. When they say never, if you know yourself very well, you can say some things. I'm not opposed to saying things I'll never do when you know yourself well, because I know I will never be a pediatric nurse. That is something I have no interest in. But I used to say I would never work in mental health. It's not for me. I would never do it. I cannot deal. And where am I? Working in mental health, y'all. However, the caveat is, y'all know I've been doing geriatrics for forever and a day, 20-something years, basically. I work with the geriatric mental health population. And so it's kind of not any different to me than working in long-term care, because y'all know some of the patients we get in long-term care, we be having to deal with a lot of mental health stuff. So it's kind of not any different, but then it's different in a way because I actually do much less work on my new job. This is going to be that job that I take it on out to retirement. Yes, I do much less work. I say I'm gonna take it out to retirement, but y'all, y'all know I plan to move, and I'm trying to figure out how am I going to make this adjustment with moving all the way 100 miles away and working that same job, because I do like the job. It's a lot less work, y'all. Mainly I do documentation.
In a quarter.
I really don't do much else. I do documentation and assessment. So let me tell you, for anyone who's an LPN that's looking to work in that field, or I would say in that field, I'm assuming a lot of places are set up like this. If you are an LPN, they do hire LPNs. They utilize the LPNs as med nurses. So the LPN job would be specifically just to pass medication. You're in this like little cubby thing. It's like, I always, when I tell people about it, I tell them it's like in the movies where the nurse sits behind a little cubby and just hands the patient, scans them, hands them pills, and keeps it moving, and the patients keep it moving, and the LPN really has no other interaction with that patient outside of maybe rubbing cream if they have a cream ordered. And that's if they do that, because they could actually hand the patient the cream if the patient is able to do it themselves. Rub cream on a patient, maybe if a patient has an order for a Band-Aid, a dressing to their skin, a treatment or something like that. They got a skin tear, they do that. Sometimes they may utilize the LPN to draw blood, because we do, in my facility, we do our own blood work. But really the medication nurse, the LPN, who would be the medication nurse, she passes medication, y'all. She gives the medication, and when she's finished her round of medication, she closes that door to that cubby, and she has her me time, and whatever she's doing behind that cubby door, no one knows. She could be taking a nap, she could be looking at a video, she could be saying a prayer, no one knows what's going on when that cubby door is closed. Okay? And when it's time to pass medication again, she opens it back up and she administers the medication, does a blood sugar, stuff like that, and she closes the cubby door again. Now, sometimes she's not even behind the cubby door. She goes and takes her lunch or whatever, you know what I'm saying? Or she goes out on the floor and she does the cream, whatever cream that may need to be done on the patients that weren't able to do it themselves, or for the BHAs that weren't able to do it or whatever. She may do that, but she passes the meds and she keeps it moving. She really doesn't do any documentation. And no documentation, y'all. She just passes the meds. Now, the system we use is one I prefer in a hospital. I did like the Pyxis in a hospital, but for where I work, I don't like it, because there are 26 patients, and it takes time to scan 20, like every med. It takes a lot of time to scan medication, but this is done to ensure accuracy in the med pass. So if you ever worked in a hospital, how you scan the patient name band and you scan all the meds, we do that as well in the facility I work. However, it takes a lot longer when you have 26 patients versus having 6 in the hospital. So yeah, they do use that system. So that kind of slows the morning med pads down a good bit, because y'all know they get the bulk of their meds in the morning. But I did it on my own the other day, and it took me 2.5 hours to complete all the medication morning med pads, besides the creams, which wasn't bad. It's just that scanning, y'all. I could have shaved off 45 minutes if I had to do all that scanning. Other than that, the afternoon med pass wasn't bad. You know, you do your blood sugar checks or whatever. And I left after that time, so I don't know how the evening med pass is. But essentially, this is what the LPN does. And you know, once you're there for a little while, you get your little routine. I love the fact that they get to close that cubby door, and it is what it is behind that cubby door. Okay? I love that. And you're working almost essentially on your own. You're working on your own, and I love that as well, because I love to not have to force communication with other people, my coworkers and stuff like that. I don't like a lot of small talk either, and so I love that. I told them, and sometimes the RN gets pulled in there if they don't have an LPN to cover the shift. I told them I'm more than willing to be the RN that has to go in there on my shift, because I love that. I love that position. So that's what the LPNs do in my job. Okay, as far as what my job technically is as the RN, I do the assessments and the documentation and the paperwork that needs to be done. So every patient has to get documented on every day. Because this is a mental health facility, we have to observe their daily, what they do daily in a routine. Now the BHAs are really observing them. They're observed by the BHAs 24/7. So the BHAs are really looking at them all day. The BHAs document if they have bowel movements, how many times they void, how much they ate, and the BHAs write it on this paper, and then they let us know. And so the BHA's documentation is very important too, because it aids us in our documentation. The BHAs let us know if they have a behavior that we possibly didn't see, and we document that as well. However, the RNs, we are enclosed in a glass enclosure. With a door that everything has to go in and out. When you have to go in every room is entered with a key. So we make hourly rounds as nurses. What we do, they normally work 2 RNs and you alternate the rounds. So if one nurse gets the even number rounds, like 2, 4, 6, 8, 10, the other nurse gets the odds, 1, 3, 5, 7, whatever. And so that's what we do. We make rounds. I shouldn't have pulled up in front of this thing, but I apologize. So we make hourly rounds. And make observations on the patient, so you can, see what your patients is doing. However, being that we're in a glass enclosure, we can see all angles except for in the pods, but we can see all angles from the nursing station, so we can see what the patients are doing throughout the shift. Now the pods are locked outside of nap time and meal time, so they have to be out in, I call it, not the community, but they have to be out in the lodge, in the day room, whatever. Now they do keep one lodge, they do keep one pod open for them to use the bathroom, to utilize the bathroom, but outside of that, they can't be in the pods throughout certain hours of the day. They have to be out and about. And so a lot of them just sit around in the day room and watch TV. A lot of them sit in the hallways in the chairs, and they nap in the chairs. They line up to get their medication. The BHAs assist them in lining up, making sure everybody comes to the line to get their medication. And we're just documenting on it. We're documenting their behaviors. We observe them doing anything. We document if we are allowed to use a restraint there. So for a patient that falls consistently, we are allowed to put a restraint on them to aid them from falling, but they have to be ambulated by the BHAs at least 2 to 3 times a shift, so that they don't lose any type of mobility. So we have to document every 2 hours on restraints. If anyone is put in seclusion, they are put in seclusion, and they have one-on-one observation and seclusion. We have to go in and check on them and see if their behavior has gotten to the point where they are able to come out of seclusion. So we have to document on them. I think it's like every 15 minutes. And it may be on paper documentation. I'm not sure, because I haven't had to do that yet. But basically the RNs, we just observe, we assess, and we document. We do body audits. So we are assigned a couple. Like the other day, I had 2 body audits I had to do. So I completed their body audits while they were using the bathroom. That was the easiest time for me to do it. So, but yeah, it really wasn't hard. The only thing that is an inconvenience to me, and it's not really an inconvenience because I'm a nurse and that's what I'm there to do. But you know, documenting, so there's 26 patients. They normally work 2 nurses. They split it up evenly, 13. Documenting on 13 patients isn't hard at all because they basically almost do the same thing every day, and you kind of document to the exception. What they're really looking for is certain behaviors. If they're not having those behaviors, you're documenting other things, like they accepted their medication, no behaviors observed, they're ambulating in the hallway, consumed blah blah blah, percentage of breakfast, lunch, or dinner, you know, stuff like that. If they refuse medication, whatever, you document stuff like that. You're not really documenting to their medical diagnosis, or to their, they want you to document more to their mental health diagnosis. If you, I guess that is medical, but anyway, it's real easy. But it's just that when you're in the groove of document, and then and you're getting called by the BHAs to, you're constantly getting called by the BHAs to, hey,
in a quarter mile,
turn, constantly getting pulled by the BHAs, hey, the patient is doing this, can you help me with this, like certain things. Now, they're not really, it's not real bad, but it's like, I'll tell them, and it's like, it's my fault, because I'll tell them, hey, when so-and-so go to the bathroom, can you let me know, I need to do their body audit, or you know, and then you're getting up every alternating hour, the hour alternating from your nurse, your coworker. Okay, so you're getting up every alternating hour to do a round, and you have to lay your eye on every resident. You have to account for every resident, and you have to lay your eye on them to see what they're doing. Now, one thing I'm so proud of myself, we have 26 residents, y'all. I'm able to identify all 26 residents. In my first 2-3 days on the floor, I've learned every resident, so I can lay my eye on every resident and I know exactly who they are. I made that my mission to learn who these residents are, because I cannot document on somebody if I don't know who they are. If I can look at you doing a behavior and I don't know who you are, then how do I know to put this behavior next to your name? You can ask the BHAs, but that runs out some time, constantly asking them, who is this, what's her name, you know. So I made it my business to learn all of them by sight, so I know all my patients now. I'm so proud of myself. Oh, I forgot to tell you about the meetings. So in the morning when I come in, the night nurse, she gives a quick synopsis of what happened the day before. And it's myself, it's the nurse, or myself, this is the charge nurse, whoever the charge nurse is. So if I'm not the charge nurse, I don't have to go, but it's the charge nurse and the BHAs that's on coming that shift. They're in the meeting with the off-going nurse. And then the treatment meeting, the charge nurse has to go. She has to give a quick 24-hour synopsis. Sometimes it goes back 48 hours on what the patient,
at the light, turn left on.
She has to give a quick synopsis on what's going on with the patient, or he, because we do have male charge nurses. They have to give a quick synopsis of what's going on with the patient, and for that last 24 or 48 hours. And so, you know, they do that, and they do that on every patient. They give them a quick synopsis on what's been occurring with the patient. The nurse does that, and then they have a where they bring patients in according to a schedule, and they ask them questions like, how are you feeling? Is, you know, if there was an issue prior, they ask them, how's that issue going now? You know, different questions they ask them, and the patients are able to say, you know, blah blah blah, or this is this. Now, mind you, this is a mental health facility, so sometimes what you're getting from the patients is some off the wall stuff, but it is what it is. They are allowed to speak on, you know, because what they're trying to do is get the patient to where they are up to discharge, because these places are, some patients will probably be there for the rest of their life, but it's really meant for you to be able to go home after this, or go to another facility, or wherever your destination may be, to get you to where you are mentally competent enough to go out into the community, and whoever's your caretaker, or you're able to take care of yourself, or whatever. That is the goal of it. And there are some patients I see there that you never say never, but I don't see them being up to the point where they'll be able to be released back into the community. But, and essentially, that's what I do in a nutshell, y'all. I'm not up 3-hour med pass. There are no G-tubes allowed in the building. You can't have that level of acuity and be in that facility. yeah, that's basically what I do. It's real easy. It's kind of boring, y'all. I'm not gonna lie, but I'm gonna stick with it because after 8 years, I get retirement from. You don't have to work with them with the state for 8 years to draw retirement, and even though retirement is until after 65, and I pray I get to see it, and I pray I get to draw it. But I'm not gonna say I'm not gonna do more than 8 years, but my goal is to at least do the 8 years so I can draw that retirement. However it may be, because y'all know in another video I told y'all retirement is like next to nothing. But just in case, I'm gonna try to stay there at least a good 8 years, if not more, y'all. Y'all know I want to retire early. I'm 46 years old. 8 years to be what, 52? No, shoot, child, what am I counting? 8 years will be 54, y'all. So anyway, but the job is easy, y'all. It's not back-breaking. It's not, you know, you're not having to deal with a bunch of family members. I do have a supervisor, and she's there on the lodge every day except for the weekend. And y'all, like I said, the pay is well enough to where I can actually only work there once I start getting paid, because I don't get my first paycheck for a month. I can just work there and really not pick up anything PRN and really be able to manage my household bills and then some, pay some things off, and I will actually be okay. So that is the plan. Once I start getting paid, that is the plan, to do that. Yeah. So anyway, y'all, I'm Muriel. Thank y'all for viewing. If y'all have any questions about anything I said, this video is probably gonna be like 35 minutes long. I apologize. But yeah, so I'll talk to y'all later. Bye.